Are you able to see my screen?
Yep. Yep.
Okay. Now, which of you wouldn't treat this pain? If this pain comes to you and I tell you, are you able to see my screen?
Yep.
Okay. This patient come to you with pain to your ER. Which of you wouldn't treat this pain? Everybody would treat this pain, right? Nobody would doubt that this patient is in pain. What about this patient? If you don't see the fractured bone, then your hesitation is a little higher, right?
Sure.
You see the swollen leg, but once you see this inside, then you have no question that this patient is in pain. But what about if I told you, and you believe me, that people who have this can have the same amount of the pain that this patient? We just have to mentally prepare ourselves that even if we don't see the pain, this patient can be in this amount of pain. And these people, they look like this. You don't see the broken bone sticking out, okay? Mm-hmm. And certainly you may say, we see a lot of patients that some other providers, some other, even professional, tell them, like surgeon, tell them it's in your head. Let me tell you, this is my patient that I did surgery on the brain. This patient can be awake. And at the end of the day, pain is always in your head. How do we know that? Because we know of people who can control the pain, like this patient or this person, he's enjoying the pain. So pain at the end of the day is always in your head. And just because we don't see a broken bone sticking out, that does not diminish the pain that patient is having. We have to be just use our discretion, and then based on our information that we can acquire, treat the pain the best we can. Now, you remember I told you the pain at the end of the day is in your head? There's a procedure that I used to do when I was doing cranial stuff, where we put a needle inside of the brain of people and we burn a very specific area of the brain. And literally, when we do that, that area is about right here. Where we burn that area, we break a pathway, and then pain is not perceived as bad as it can be. Like literally, pain is the pain, what we understand, there are two parts. There's acute pain, and pain after the surgery is always acute pain. Doesn't matter if the patient had 10 years history of pain. The pain after a surgery always in acute pain. But there's a part of pain, we call it chronic pain. The chronic pain is a pathway that develops in the brain. Let's be very clear about that. If you do not treat acute pain, you put the patient at the most risk to make that pain chronic. So that is why one of the things is we do not discuss, we do not negotiate, we do not try to get the patient off the pain medication right after the surgery where we put 10 screws in the patient. So, because if you do that, the most likely you're creating a path for the patient to have chronic pain. And the proof of that is this procedure, that is how we break chronic pain. Obviously, it has some other side effect. That's why we don't do that on everybody. Now, pain is not the problem. Pain is a noise of a smoke alarm. That is what I compare the pain, what it is. It's a noise of a smoke alarm. It's that somewhere in your house, there's a smoke, maybe something is burning. But chronic pain is now like, it is a necessary kind of signal. Pain is a signal. It's a necessary signal. There's a disease that the receptors that produce pain they're modified. They don't exist. These children, by the time they are 6 years old, they lose their fingers. By the time they are teenager, their hands is like a stump. They do not have hands and feet because they don't learn that don't touch sharp stuff, don't touch hot stuff. So pain is a necessary signal. When it becomes a problem is when we have a pain that we don't treat, it become its own kind of symptoms, and that is to become a problem. Another thing is, let me repeat, once you kill the nerve, pain goes away. Now, dead have no pain. A grade 4 burn is painless. I received the Texas City explosion in 2002. Most of you are not old enough to remember that. We have grade 4 burn where the burn is all the way to the bone. We put those patients on a what we call a burn table, which is almost like a morgue table. I took a 2-inch blade scalpel. We slit them down to the bone, and we didn't have to anesthetize them. So, and it's important for what we do. Contrary to open surgery, where we put electricity and burn everything, create, at least for the muscle and the nerve, grade 4 burn. Our patient, we poke them, we create grade 1 burn. So if we are not prepared, our patient can wake up even worse than somebody. Like, first time I went to Missouri, helped another doctor there. He used a 120-volt bipolar, literally cooked the tissue in the surgery. You would see the color of the muscle would turn from a regular pink to like a steak color. Those patients initially wakes up without pain because everything that perceived pain is gone, but they then need a year of your recovery. Whereas our patient may wake up, if you are not prepared, they may wake up in horrible pain. They may scream. That exactly happened they are used to in Missouri. They were used, this patient wake up, they are lethargic, they have no pain. Our patient woke up, start screaming, and everybody was, my God, what did you do to the patient? But the difference is those other patients, they have 15% risk of infection because you kill all the tissue, all the muscle, and they stay 2 weeks in the hospital. They need a year and a half to recover. Our patient, they woke up in pain because they weren't used to treat that, but next day they still went home. So that may still happen in our surgeries if you are not prepared. You have to prepare to manage our patient because we create grade 1 burn compared to in this scale. Now, I'm not going to go through the pathways, and I'm not going to talk about that, chronic pain is a human thing. Animals don't have that. There's a video, they brand this cow and start screaming, but then start running and grazing 30 seconds later. A human wouldn't do that. If I come and brand you, you wouldn't just stand up and go about your day. You will have yes, true, lots of pain. What we perceive is emotional response to the pain, not the pain itself. But nevertheless, pain is a signal that something is burning. I'm not going to go through the path of how the pain is. We understand that. We understand how to modify it. But I want to just tell you there are other kind of pain. The pain that the receptor itself, the path itself, shooting wrong signal. It is like again, pain is that the noise of a smoke alarm. Sometimes the smoke alarm itself is damaged and then start shooting signal that's not real. Now, some of you have seen that. You see the house in fire.
Mm-hmm.
Sometimes it's not, it's just our brain simulated. Okay, sometimes the problem is our brain simulated and it's not a real fire. But for people who have that, it's the same. It makes no difference if the pain is real once your brain perceives it as real. And you remember I told you that all the pain is in your brain at the end of the day? Look at that. You can control it. So before you tell anybody they should man up and go control their pain or be tough about that, I want you to do what this monk in Cambodia did, setting himself on fire and sitting, meditating all through being burned down. So he can control his pain, obviously. Okay, most of us, we cannot. So we shouldn't ever tell anybody they should toughen up the pain. We should be more respectful, more empathic toward our patient, even though for many of them we know they could probably do better than what they present to us. Okay, but it is at the end of the day, it's about what's happening. Now, I'm going to jump through many of these pathophysiology of the pain and come back to what really matters to us. Okay, come to treatment. Obviously, opioids are a big part of pain management. We understand how they work. We understand how they affect the central perception of the pain. There are other ways that we can manipulate the pain where it's produced, in so-called the nociceptors. Those are two pathways, prostaglandin and the other pathway, that we treat them with medication that we call them non-steroidal anti-inflammatories. And here, let's talk about what's important much for us, which is the so-called opioid, which is our central pain modulators. Now, the problem with pain modulators is that they don't just work on the pain receptors, they work on much more. And the bad part of that is that our receptors, there is a receptor regulation, meaning that we regulate the receptors up and down. So if you have more of that, and again, every medication works because we have an internal corresponding chemical to that. We call that endorphins. It's a protein, actually. And don't ask me why nature thought a plant should build something that mimic that. Most likely because when the other animals eat that, they slow down, then they don't eat as much of the plant. But they work on our spinal cord, on our brain, but unfortunately, they don't work only on pain receptors. And almost every part of the opioids we get used to, we upregulate or downregulate that, except the part that affect our breathing. Our breathing doesn't get used to that. That is why we have to be very careful, because your body gets used to it once more and more, but your breathing part doesn't get used to it. All of a sudden, you quit breathing and you die. And that, hopefully, everybody knows that happen all the time. So you have to be careful, but there are rules that will help us to understand how to adjust that. Now, I'm going to become very practical. We are not going to use PCAs anymore, even though it works. In some cases, in certain cases, in rare cases, in the hospital, Alyssa, we are going to use PCAs, patient-controlled analgesia. We determine a range. We can talk about the range, but that is a different conversation. But that within range, patient controls it. The thinking, and it works, is that if the patient is too lethargic to push the button, he or she just doesn't, and that's what makes it safe. It becomes dangerous when family or a good minding nurse with good intention start pushing that button for the patient, whatever reason that is. So never ever somebody else push the button except the patient, and that is within the range. Dilaudid is used, and sometimes you will see us using it in the hospital for rare cases. And then, depending on the situation, we usually start at something like 0.2 milligram per shot, but then you can give those shots 15 minutes, even can go all the way down to 6 minutes. So within range, and then you identify a maximum. That maximum, usually I prefer not to be 2 to 4 milligram per 3 to 4 hours, but based on individual situation, you can dose it. What you can as well put them on a basal rate. I don't like that, because that basal rate just can accumulate. I rather patient being awake and giving that. Well, the nurse will come and tell you, no, but patient fall asleep and wake up in pain. Well, that is a safe thing. Patient that wakes up to push the button, that's always preferable that the patient that slowly become lethargic. That is when you get in trouble. One of okay, let's go talk. We are not going to talk today about much of the adjuvant therapy. In the office, we will deal with that. That we give people antidepressant all the time. We give the the other anxiety medication all the time. The cannabis has been very, very effective to dissociate the perception of the pain with emotional response to that. As a matter of fact, it's well known that cannabis actively help you to forget any kind of memory, including the pain, meaning that it reduces that the pain become chronic. People who had the same pain, they rate the pain the same way. If they're being given cannabinoids, 2 weeks, 3 weeks, 4 weeks later, they remember the pain much less. So let's jump to our pain management in the post-surgery center setting, okay? The pain management post-surgery center setting starts with pre-surgery, that we tell this patient, you will have pain. We prepare them for the pain. We tell them the pain can get worse 3 to 7 days after the surgery, and we prepare them for pain related to nerve irritation. Once we start that, patients become more compliant with what we do. After the surgery, there are 3 medications that we give. Alyssa, can you tell me what those 3 medications are that we regularly give?
Yeah, we typically give methocarbamol or Robaxin, typically oxycodone, acetaminophen, and then a hydroxyzine.
So 3 categories of medication: narcotic, which we just talked about, and we will talk about the dosage later. Then the second category are muscle relaxant. We give Flexeril or Robaxin. Flexeril, we give it 10 milligram. We can give it regularly every 8 hours, but sometimes we can go to every 6 hours. Vistaril or hydroxyzine is an anxiety medication. It's a pain modulator. I used to not believe in this, but I do very much believe in that. In combination alone is not a pain medication, but in combination with Robaxin and morphine or hydroxyzine or narcotic, it modulates the pain and really helps patient to require rest narcotic. We start at 10 or 25, but then literally we can go to 50 Q6 hours. It's a safe medication, and if we prescribe it, you can easily prescribe it for 3 or 4 refills, 60. So more or less, in the first 2 to 4 weeks after the surgery, patients should be on that around the clock, because especially people who are less experienced, especially nurses in the hospital or surgery center, this is the last thing they give. This should be the first thing they give. And Robaxin the same way. So now narcotic, obviously in the surgery center and in the hospital, they come PO and IV. Now what's important, and everybody loves to give the narcotic IV first, but narcotic IV build up a level fast and it goes down fast. So and the only reason we should give IV narcotic is, number 1, patient cannot take PO, and number 2, after giving a Vistaril or hydroxyzine, Robaxin, and PO narcotic, pain is still significant, and we maximize all the pills, all the POs before we give IV. Okay, so IV narcotic is, even though for most of people's staff is the first choice, it should be the last thing truly for breakthrough pain. Another thing that we do in our surgeries, both in surgery center and in the hospital, we talked about preparing patient for the pain after the surgery is the first step. The second step is the surgery itself. If you cause less damage, you have less pain, even though they may wake up in lots of pain initially, which you have to be prepared for, but the pain usually the next day gets so much faster, so much better. So, but in the surgery, we obviously give the local anesthetic. The local anesthetic that we give, and that's important for you, Sarah, is the mixture of lidocaine, 1% with epinephrine, which as well reduce our blood loss, and 0.25% morphine, half-half, usually a mixture of that, and the lidocaine is with epinephrine, the bupivacaine is without it. and then 50%. We give usually 10 to 20%, depending how many levels we do. And the reason we do that is too much lidocaine can be toxic. And the mixture, bupivacaine doesn't have the same limitation as lidocaine, but as well, it lasts longer. So it gives us more. Now, most of our surgery is so short, I could go and give lidocaine because we don't do that 7-hour surgeries that the effect is gone by the end of the surgery. Our surgeries are shorter, so we could give just lidocaine, but that as well help after the surgery for our patient. We don't rely on that alone. We put 0.75 lidocaine, so small little depots in the muscle, paraspinal muscle, or as well, we can give Exparel. Exparel is a so-called the liposomal lidocaine that because it's liposomal, it doesn't get absorbed right away. It takes 3-4 days before it's all absorbed. And there is a good indication, and I need you to look it up, Sarah. Now, I usually mix it half with normal injectable normal saline, but they say you can actually mix it with bupivacaine, and that doesn't limit the amount of what you want to give. Maybe we should start doing that. So please, one of our change in our protocol will be, instead of mixing the Exparel with the injectable normal saline, mixing it half-half with bupivacaine. That seems to be the current recommendation. And as well, at the end of the surgery, I put epidural steroid injection. That can be as well very effective for surgery. So before the surgery, preparing the surgery, the education, physical therapy, teaching them what to do, what not to do. So that should be part of our protocol. During the surgery, skin injection or injection that bupivacaine, lidocaine mixture, 0.75 depots, or Exparel half with bupivacaine. This is going to be the change. Please, somebody change that in our protocol. But then as well, epidural steroid injection. Now, before patients wake up, we ask the anesthesiologist to give 30 milligram of Toradol. That as well can make a huge difference in immediate post-operative phase. After the surgery we talked about, we maximize everything else before we give IV narcotic. But obviously, if they cannot take PO, then because they are nauseous right after surgery, then they have no choice but starting IV narcotic. And IV narcotic for us, for all practical purpose, is going to be dilaudid. Morphine is good, but dilaudid is better. It gives you a better, steadier pain control. Anesthesiologists, they love to give fentanyl, and they're entitled to do that, but that's not our preference. Michael, why do you think fentanyl is not my first choice for post-operative phase?
Is it because it causes more respiratory depression?
No, actually, because it peaks up very fast. The reason it causes more respiratory depression is because it peaks up very fast, but it peaks down very fast too. You have to be dosing it right, and you have to be standing there every 5 to 10 minutes, push another thing. So it very fast absorption and very fast, our body gets rid of it, makes it harder to control, keep a steady level. Okay, so but anesthesiologists, for certain things they can do that, but anesthesia in our system, only anesthesiologists should do that, and they have to stand by. They cannot give fentanyl and walk away. For same thing, it peaks up fast, then it can cause respiratory depression pretty fast. Dilaudid is much better in that regard, and that's safer. And we still have the criteria to give more narcotic, dilaudid or pills, is, for the patient to be able to communicate with you, being awake, alert, oriented, making eye contact, and literally talking in full sentences. Then you're always safe to give more narcotic. If patient is just uncomfortable and you have to wake up the patient to open the eyes and tell you the pain is 10 of 10, that is when you get in trouble. So a patient that who's awake, alert, oriented, looking at you, making eye contact and talking in full sentences, more or less can have pain medication without any kind of concern, but not obviously every 5 minutes. You give that in medication, you wait at least 15 to half an hour, 15 to 30 minutes before you give the next dose. If that's not enough, then you can modify it and go higher up. Okay. So, but if the patient right after the surgery is in lots of pain and is able to communicate that pain with you, you are safe to give even in shorter intervals pain medication. Again, we talked about that. That depot of Exparel in the OR, 30 milligram of Toradol before they wake up. Those 3 pills we talked about, Visceral, Robaxin, Dilaudid, and then as well, Dilaudid is the IV, and OxyIR or instant release is a pill form, a very potent form of it. We can as well give Dilaudid pills, but the OxyIR is the preferred route because it builds a more steady dose. Okay. Any questions so far?
My only question is, kind of, Sarah, do we have this written down on a protocol, like that's on a sheet of paper somewhere in the ISSC, just for in general being able to look back?
No, but I think that's a really great idea.
So
Yeah,
we have
sure.
it. We have it in our protocol. This is what we enforce in Maple Grove Surgery Center. Now, just find it. It should be some other place in Inspired Spine. In the folder Inspired Spine Health, we have these protocols. In the Inspired Spine Health, we have this protocol. There's another folder called Inspired Spine. There we have protocols as well. You should have a copy of that there.
Okay. Yeah,
Okay.
I agree. We should have one in the surgery.
We are recording this. Based on that, create that protocol. Okay. Another thing that we give in the hospital, and there is no objection to give it as well in the surgery center, is Toradol. For elderly or people with a kidney problem, we start 15 milligram IV every 6 hours. I give it usually maximum 48 hours or 2 days, so 8 doses. But in selected group of people, we can as well give them a prescription for 8 doses, total of 8 doses to take home. 15 milligram is most of the time enough. In a big person with lots of pain, 30 milligram is a more appropriate dose. And we should have as well in our surgery center Toradol, both pills and IV. In reality, they both work same way, and pills work very well, but literally you get more placebo effect if you give it IV. Okay, and don't
Just to
underestimate.
clarify, Dr. Abbasi, you said you do want us to have oral Toradol
Yes,
on
please.
hand
Both
as well?
orals and IVs.
Okay, I don't think we have oral currently, but I'll get some ordered.
Yeah. So in the IV form, you get a more placebo effect, but do not underestimate the placebo effect of any pain medication. 35% of the pain medication's effect, it's always attributable to placebo effect, and IV has always higher rate than PO. Okay, so now one thing that we did not talk about and we need to add to our protocol, which is not part of our protocol, is ketamine. You remember the part that we talked about, the huge effect the part of the pain management is emotional response to that, and especially in chronic pain patient, that can be half or more of the pain what they perceive. Now, ketamine by itself is not a pain medication, and it's not something that we give regularly. But a handful of patients where they have a huge emotional response to the pain, like I can tell you a handful of them in both hospitals or all hospitals I have been working, you give them pain medication until they fall in coma, but as soon as they wake up, they start screaming. We will get those patients. And in those patients, you always are in the danger that you put them down to a point that you have to reintubate them. in those patients, ketamine is like a magic drug. And I can give you individual examples of patients that they are sweating, their pain is real, and so on, and no amount of narcotic can make the pain go away except they fall in coma with pain medication, and you just have to bag them. But then you give them 100 macrogram, 200 macrogram of ketamine, they are normal people again. Normal people. Like everything, all the symptoms go away, they talk to you, and then you watch them in the next 10 minutes, the ketamine level goes down, and then they go back there. We put them even on a so-called ketamine drip. As a matter of fact, Alyssa, find out, it should be in one of our protocol, but find out what the proper bolus and proper initial dose is. Proper bolus seems to be for a 70 kilogram person, somewhere between 100 and 200 microgram, and the bolus, and the dosage seems to be somewhere around 70 to 100, I believe, macrogram per minute or something, macro, not milligram, macrogram per minute. But why don't you find out the exact dosage that I should have it somewhere, but in our protocols, but let's look them up, okay? I'm going to go through this. We talked about the ketorolac or Toradol. I do not like Valium. Let's be very clear about that. Valium sedates, whereas Flexeril does not. You want to get them out of bed, okay? No sedation. Combination sedation and pain medication, narcotic is a bad combination. Sometimes we have to do that. Now, there is this medication that you see, there are pain modulators, and Tara, you know that we often use that for post-operative neuropathic pain, where 15% of our patients, they may have nerve irritation, but much lesser degree, maybe 3 to 5% do have neuropathic pain because we have to push the nerve to the side. First, we tried the gabapentin, then carbamazepine and the Keppra can be additional pain, okay, pain modulator. We should have another talk about the pain management for post-operative, post-OLIF pain. But if they have nerve irritation, which again, 15% of the people may have nerve irritation, to lesser degree, about 3 to 5%, they may have neuropathic pain, then we start gabapentin and other medication. With the gabapentin specifically, Tara, you know we have a protocol, we go up slow, we go down slow. And we don't take it PRN, we take it. That is, if you start it, that should be the last medication you come off. That should not be the first medication you come off. And we build it up now, because if you go up too fast, you will have cardiovascular problem. Outside of the hospital, you go up slower, because inside of the hospital, you can get blood pressure and they are more in bed, you can go up faster. So in the hospital, we have a protocol. In the hospital, you can start 300 TID, next day 600 TID, third day 900 TID, you're already at your optimum dose. You can go to 1200 TID but for specific patient, but 900 TID is the optimum dose. So below that, you don't really expect much of a result. So people who come and take one Neurontin in the morning, PRN, that's practically, they get only the placebo effect of it. Outside of the hospital, 1 pill, 300 first day, 2 pills next day, 3 pills next day. So 3 days before your 300 TID, and then 3 days, every 3 days you go up slowly, because then if they have cardiovascular, they adjust better to orthostatic regulation slower. We don't want them to fall outside of the hospital in an uncontrolled place, okay? So much slower outside of the hospital. Now, we talked about most of this here. For the nerve irritation after our surgeries, if the gabapentin is not enough, we can try other things, but more importantly, we can give them nerve root injection, epidural steroid injection, nerve root injection, steroid, like I would say like a Medrol dose pack, they have limited effect and more side effect. We generally trying to get away from steroids, but in selected people as well an option. If you are going to do that, dexamethasone 2 milligram Q6 hours for 2 to 3 days, or Medrol dose pack is a proper thing. You can, again, go listen to back, Alyssa, and everything we talk about is our protocol. Too bad Michelle Lavelle is not with us because she has a lot of information, additional information.
I'll see if I can get her for the post-OLIF pain management
Okay,
one.
so I'm actually done with what I want to say. Do you guys have any question or comment or additional information we need to share?
The only thing I thought about was when you sent over the standing orders protocols from Crookston, whatnot, and then I saw your protocol that Tara had said was probably a couple of years old. That looks like the snake table. Just kind of there are some discrepancies between it, but I just want to make sure that we kind of have just a standard protocol ready.
Discrepancy should be minimal.
It is minimal. I just sometimes it's just nice to have one that we want for our facility.
Sure.
Not one for Crookston, one for here, one, so at least we have the consistency. I know patients are still patient to patient basis. We understand that. I just think it's best that if we're going to have.
Let me show you those protocols, okay?
Yep.
So. Spine determination, biologic, fluid protocol, teleconference, pain management. Okay, here.
Yeah.
You see, we have
I've
those
seen that one
protocols
million
already.
Yep.
You just have to update it with the information I just gave you. Like,
okay. I think I was thinking more from
I'm going to tell you,
day
get
90.
them.
Yeah.
Okay, so we have that protocols, so we just have to update it. This is what you need. Find out where it is, laminate it, put it in your surgery center. Okay. Now, and you see every year we update it and so on. And I'm going to now get that snake, what you are talking about.
Yeah, I have it pulled up too online.
You want to share it then?
If I knew how to share it, I would, but I can just forward you the email too if you don't, because I shared.
I have it. I have to find it. I just have to find it.
Share my screen.
So at the bottom, Alyssa, there's a
I never do this.
Okay. Now it seems complicated, but it is not.
It's not.
Okay. So we have patients that they have never been on narcotic. We can wean them faster. They are inside. We have patients who have been 5 years on narcotic. They are outside. We wean them slow. We go down very little at the time. If you go too fast, you exactly achieve what you don't want, that you have to catch up with the pain. If you try to catch up with the pain in postoperative phase, sometimes it's hard to catch up. Now, a patient can start based on our best judgment on one of these paths, and you see there are 4 of them, but they can move from one path to another. They can go from fast taper to a medium taper or slow taper or very slow taper based on our judgment. But when they are in one place, practically, if the pain gets worse, at least in the perioperative phase, we can go up on the medication or down on the medication based on how they are doing. The first month after the surgery, do not fight the patient on pain medication. Okay? So now what those numbers are is just about to go up and down in a slow or fast way. And those numbers we can change, but this is what we came in. And I think that still applies. This is about, mostly it's about that patient is, let's say here on this path, it's getting much better. Then we can move the patient either down on the medication or move it to a faster taper. And
I think, sorry, the question I guess I have is when we come from patient cases, a lot of the times the patients, they aren't scheduling anymore. So they'll be at, Percocet 10, 325, and then a month and a half later, they want a refill. And if we're looking at kind of the order, they're not on Percocet 10, they might be down to Narco 5 based on protocol on when, they need the refill and how they're spacing. And so my thing was, I don't want to give a patient 2 months out Oxy 10 just because they had that to begin with. I was looking down the protocol, but then we don't have technically titration because they're not going,
This
they're
is
not
the
refilling
titration.
every week, which is,
No,
we
you cannot give
expect them to.
anybody in 2023. You cannot give anybody 2 months of narcotic. You literally cannot do that. You cannot order. Pharmacy wouldn't accept that.
Correct.
Insurance wouldn't pay for that. No, that is a more discussion about you just getting used to, these protocols. We talk
Yep.
about that in person and we go that, but let's, for all practical purpose, if the patient, this is what you are. Patient is on a medication, you can find that medication here
Mm-hmm.
and find on which taper the patient is. And if you have question, let's talk about it. Based on patient's previous information, I can help you to find out on what taper this patient should
Yeah,
be.
I don't think
And
we've
then-
had difficulty so far, like figuring that out on our own. I just wanted to see if we were going to have a protocol, just kind of how basing it. But no, I got the resource.
This
And
is the
I'm all
protocol.
for figuring that out. Yep, figuring that
Tara,
out.
you have been using this for years now.
Yep.
How is it working?
For Tara, I mean,
Muted. Yeah, I mean, it seems to work fine for patients. And I get what Melissa's saying. There's some patients that jump around.
Yeah, and that is a judgment call.
okay.
I
And
have another
that's all I
meeting.
need on that.
Okay, there's
judgment call
another
based on
meeting I
protocol.
have to go right now. As a matter of fact, I'm 25 minutes late for that meeting. Any additional question regarding this?
Nope, we can figure
Okay.
it out the next meeting.
Okay, then based on this conversation, you can just go back and listen to that, modify those protocols, and then we should set up another meeting with Michelle Laval,
Sure.
Michelle Henry, and then do additional update. Okay, thank you guys. I have to go.
Thank you.